Good morning, everyone. It's my pleasure to introduce Dr. David Millett. Dr. Millett is the Epilepsy Director at Hoag Hospital, and today he's going to be discussing understanding your EEG, and it's my pleasure to introduce Dr. Millett.
Thank you. Thanks, Patrick. Good morning, everybody. Some familiar faces in the crowd. Always nice to see people back. This, I don't know, is this, who's here for the first time? This meeting, yeah? Wow. Big room of first-timers. So we've come a long way from the first year. We had a bar stool set up in the corner of the convention room and maybe 9 chairs in a semicircle and just answering questions. So we had just maybe 100 or a couple hundred people show up those first few years. So it's really nice to see everybody coming, especially you first-timers. Hopefully you're getting a lot out of the meeting. So I am I'm Dr. Millett. I established and run the epilepsy program at Hoag Hospital. I've also been involved in another epilepsy center up in Los Angeles, Rancho Los Amigos, and still participate in those in our surgical conferences and case discussions and decision making. I also work very closely with Brad Levy, who's one of the producers and organizers of this meeting, in interpreting ambulatory video EEG. So I read a ton of EEG. I probably read more EEG now than I did in training, which is usually the opposite. So I'm going to talk to you a little bit today about understanding your EEG. I like to run this in a sort of half didactic, half question and answer session. So I'm going to talk for about half an hour, maybe a little bit more. I'm going to try to illustrate some of the basics of EEG and the limitations of EEG. And then I'm going to sort of open it up for questions towards the end. I always like to start with this slide, which sort of brings me back to the beginnings of our field. EEG, or the recording of electrical activity of the brain, was discovered / invented by a psychiatrist, a neuropsychiatrist in Germany in the 1930s. His name was Hans Berger. He believed actually in mental telepathy. He believed that it was possible to send thoughts across time and space from one person to another. And the discovery of EEG was sort of an accidental finding as he was trying to understand how energy is produced and consumed in the brain. And so obviously the primary energy mode of brain communication is electricity, and so he was trying to record electrical activity of the brain, and with very rudimentary amplifiers that you can see in the lower left-hand panel, he was ultimately able to record 2 of the primary rhythms that we talk about today: the alpha rhythm and beta activity. In the middle panel, which is a team of 3 physicians, William Lennox and Erna and Fred Gibbs, they worked very intensely in Boston, at Boston Children's Hospital. And at that point in time, the EEG readers or recorders consist of essentially a stenograph that scribbled 3 or 4 or 5 scribbles on a long piece of paper that ended up getting rolled into these scrolls. And you can see the scrolls that are bundled up and along the back of the wall. So that's how they used to read EEGs, was by unscrolling and scrolling these long reams of paper. And that form of reading EEG, whether it was on scrolls or on folded pieces of paper, really persisted through the 1980s. And it's really been only in the last 25, 30 years that we've had the luxury of digital EEG. which I'm going to focus on today. The two right-hand panels are scenes from operating rooms in the 1940s and 1950s in Montreal when they first began to use EEG to guide epilepsy surgery, so the identification and removal of areas of the brain that produced seizures. So a little bit of history of the field. And I am going to, let's go to slide number 2. So these are examples of different types of EEGs that we currently use today. All of these examples, except for the one in the lower right-hand area, are surface EEGs. So they're basically illustrations of different ways in which we can record electrical activity of the brain from the surface of the head. On the left-hand side, there's a diagrammatic illustration of something called the 1020 system. The 1020 system was developed by Herbert Jasper, who was working in Montreal. He was actually in some of those figures from the operating room in the 1940s. And it became clear by the late 1940s, early 1950s, that EEG teams around the world had to have a standard way of understanding where the electrodes were and how the electrical activity of the brain was going to be represented. And so he developed something called the 1020 system, which is now universally utilized in every country that has an EEG lab, has an epilepsy department, performs epilepsy surgery or brain mapping. They use the same system, which basically identifies, based on coordinates, measuring from the nasien, so this little divot just between the eyes, to the inion, the ridge at the back of the head, and taking that half circumference and then the circumference around the outside of the head horizontally, you can then divide those figures up, those numbers up, by either 10 or 20% of the total, and that's how our EEG technologist today, anywhere in the world, knows where to put electrodes on the surface of the head, so that if you have an EEG in Bangkok, or you have an EEG in London, or you have an EEG in New York, or you have an EEG here in Anaheim, those electrodes are going to be in the same place, and your epileptologist, your reading neurologist, is going to be able to interpret the same type of data. There are products that are available that actually embed approximate electrode positions in a skull cap, which you can see in the middle upper panel. So you basically just have to inject a little bit of gel into each one of these electrodes to make contact with the brain, and they're completely, these are preset. They make it a lot easier to apply and remove electrodes for routine outpatient EEGs. The upper right-hand panel of the boy, the child, is a standard paste and tape. These are silver chloride gold electrodes. That's what they tend to be, and this is that's a very traditional application of EEG electrodes for long-term monitoring. We would tend to wrap the head to secure the electrodes in place. In the middle on the lower panel is a newer product. There are a few of these on the market that basically offer more limited number of electrodes, but they're very easy to apply in emergent situations in the ER, or even overnight when we may not have an EEG technologist available to apply the electrodes. Somebody may have had a seizure in the hospital but has not returned to their baseline, and it's helpful to have essentially a headband with embedded electrodes we can just strap around the head, and again, doesn't require an EEG technologist. It connects to the hospital Wi-Fi and can beam the EEG signals up so we can read it remotely. And then finally, in the lower right-hand corner, you see, although it looks very much like electrodes on the surface of the head, those are actually the pins or the caps of depth electrodes. Those are that's the tip of typically a 4, 6, 8, or 10 centimeter long electrode that's actually inserted into the brain, sampling from multiple areas. This happens to be sampling from the right temporal lobe. But this has been sort of the way of the future in sampling from deeper structures of the brain with what's called stereo EEG, utilizing multiple of these depth electrodes inserted in very close proximity so we can understand exactly from the depths of the brain where seizures begin and how they spread. Please stop me at any point in time during the conversation. I'd like to make it a conversation and ask questions if you have any, if there's anything's confusing to you or you want some more elaboration. Yeah, yeah. So I think the next slide is probably the next slide will probably answer a little bit of that. So because it doesn't really matter which one of those different ways you apply the electrodes, there are still inherent limitations in the EEG. So we typically talk about routine EEG. So routine EEG is a 20-minute EEG typically done in the outpatient clinic. Sometimes, if it's not in the doctor's office, it can be done in a neurophysiology lab or even in the emergency room. Somebody comes in with first lifetime seizure. Sometimes we'll be able to get an EEG from the ER. But those are all 20-minute EEGs, and they have limited sensitivity in terms of detecting epilepsy discharges or epileptiform discharges from the brain. We know that in a population of patients who has epilepsy, they've had more than 2 lifetime seizures, they're typically on medications. The first routine EEG is only 20 or 30% sensitive, which means only 20 or 30% of the time for somebody who has epilepsy is that first routine EEG going to be positive. It's going to show the discharges. If you perform 3 serial EEGs over the course of weeks or months, that sensitivity goes up to about 70%, but really not much higher. And then even when we hook up patients with known epilepsy for 3 days in our epilepsy monitoring units, the video long-term monitoring only is about 70, maybe 75% sensitive in identifying epileptiform discharges. So there are patients that, although they have seizures, although they have epilepsy, the scalp EEG is just not picking up their activity. So why is that? And so the bottom part of the slide and the diagram on the right is an attempt to sort of illustrate some of the limitations, the spatial limitations in terms of detecting EEG. As you can imagine, if we have an electrode right over this, I don't know if you guys can see my. Can you guys see the cursor? If we have scalp electrodes located here over the surface of the brain, these are going to be quite sensitive to certain dipoles or certain moving electrical charges. So anything that's oriented radially, so from the center of the brain outwards, like that white arrow that you see in the pointing diagonally in the upper right-hand corner, that's going to be a perfect abnormality for detection by electrodes placed on the surface of the brain. We are not going to miss that, okay? But unfortunately, there are lots of other places in the brain that seizures can come from that don't have such a clear-cut projection to the outside of the head. One of them is what we call the interhemispheric fissure. As you can see, the frontal lobes dive down, and there's a significant amount of cortex in the middle part of the brain where the gray matter is facing each other, and that area, that horizontal dipole or that horizontal arrow, will not have a great projection to the surface of the head. Electrical dipoles, or the electrical charges that we are able to detect with our electrodes, they decay or they get smaller the further they are from the surface of the head. So anything that's deep arising from deep inside the head will not be as easily seen as something that's arising from cortex just underlying the surface of the skull. Similarly, if we have a dipole that points upward from one of these deep structures, there's going to be a field, but it's going to be splayed very, very wide. And even with electrodes located on the surface of the head, here, we're not going to see a very clear EEG spike or spike in wave or sharp wave. It may be highly attenuated or reduced by the depth of the source of the dipole and then the orientation of it. And finally, we have areas of the brain, for example, on the floor or the bottom of the temporal lobe, where the dipoles, they're on the surface, they're just not pointing towards where we've got electrodes. They're pointing down towards the neck. We are never going to see those electrodes or those dipoles with electrodes located on the surface of the head. So these are some of the inherent limitations, both temporal and spatial, of scalp EEG recordings. Temporal, in that some patients simply don't have a lot of spikes wherever their seizures are coming from, that it just isn't generating a lot of abnormal electrical activity in between their seizures. And for other patients, whatever the lesion is or the abnormality in their brain that's generating the seizures is located or oriented in such a way that we have real difficulty detecting those abnormal rhythms or discharges with our standard placement of electrodes outside the head. No, temporal just refers to time in this instance. So it just means that a routine 20-minute EEG has a very low sensitivity. One of the questions that I almost always get following this talk or in the middle of this talk is, I've had 7 EEGs, and every time they say we don't see anything, we don't know that you have epilepsy, or we can't find out where it's coming from. And I'm just trying to illustrate for you that there are many patients who, certainly on one routine EEG, even a second or a third routine EEG, 30%, 35% of people with epilepsy, even after 3 routine EEGs or 3 days in the hospital, normal EEG, still have epilepsy. We just can't see it. And then the spatial just sort of illustrates the why. And it has to do with where the seizures are coming from and how that electrical activity projects, and unfortunately, or doesn't project, to the areas that we have electrodes.
So it's based upon the area with the electrodes?
Yes. Yeah. Yep. Yeah.
So if you were on the frontal lobe or in the parietal lobe, there's multiple lesions coming from the parietal lobe, stuff like
Yeah.
that. That would be
It would depend on where it's at in the frontal lobe, because again, the frontal lobe, just like the temporal lobe, has there's a convexity, there's a surface to it that lies just below the skull, but then it folds under, and then there's the undersurface, the orbitofrontal, the gyrus rectus. There are anatomical structures or surfaces along the underside of the frontal lobes that essentially project into the eyeballs or to the back of the eye sockets, right? And we are just not gonna see that on scalp EEG unless we slip electrodes through the skin, the fascia, the bone, and under the subdurally on the surface of the brain. Yeah, and so that's typically a time where we would take either our EEG data and apply some sophisticated algorithms, source imaging, or send a patient for a magnetoencephalography. because those two techniques, either looking at the magnetic charges or applying some complex mathematical equations, will help us to localize exactly where within the brain those discharges are coming from. And I can show you a little bit later if you're interested. I have that in a different talk. Yeah. So let me just talk a little bit about about the different rhythms that we see in the brain. This is a slide that's you'll see in a number of talks. It's a kind of a standard depiction of the different waveforms. So beta tends to refer to is the top line, the top tracing, and it tends to refer to low amplitude, so not very tall, flat, fast activity. So you can see it's kind of dark, it's sharply contoured, as beta oftentimes is. Below that we see alpha, and that's rhythmic activity, typically in the range of 8 to 13 hertz. So within hertz refers to the number of cycles or the number of waves per second. So we tend to see in the alpha range about somewhere between 8 and 13. Most commonly, it's 9 to 10 cycles per second, and the alpha rhythm tends to make up what we call the posterior dominant rhythm over the back of the head. You can see right below alpha it says occipitally, so we tend to see this alpha rhythm kind of coming and going, waxing and waning in this envelope pattern over the back of the head. Those are normal rhythms. All of these are typically normal rhythms with the exception of the bottom one. So theta is slower than alpha. It's in the range of 4 to 8 hertz. Theta can be normal, in young children. It can be normal over the temporal lobes or over the central midline area in school-aged children, and even during drowsiness in adults, theta can be normal over the temporal lobes. As we get older, you see less and less theta until patients over the age of 60, 70, we can see the reemergence of theta rhythms back into the normal brain. We do tend to see a lot of theta, and then below theta, the delta activity. We tend to see a lot of that in sleep. So delta activity is common in infants and in sleeping adults in what we call slow wave sleep. And then the bottom line just depicts what a spike in wave discharge tends to look like. This is one channel. I have a lot of examples sort of in the slides that follow. Let me just grab my phone so I am sure that I'm leaving enough time for Q&A. So here we have an example of about 4 seconds or 3.5 seconds of normal EEG. So this is a tracing from or a normal tracing. I don't know whether the patient actually has epilepsy or not, but this 3.5 seconds of EEG is completely normal. What you can see is that the EEG that we're reading on the computer screen is a 2-dimensional depiction of actually 3-dimensional activity over the surface of the head. Each of these lines tends to reflect the electrical activity of one spot on the brain compared to an adjacent spot on the brain. So, for example, this first line here on the second shade reflects the electrical activity here at the right frontal electrode here compared to F8, which is just sitting over the anterior temporal lobe. So when you take these 2 points over the surface of the head and compare or subtract the electrical activity of one from the other, that leaves you with a squiggle. It leaves you with a residual, a difference in voltage, and that difference in voltage is what's depicted in one of these lines on an EEG figure. Yes? Yeah. No. Bipolar here refers to the fact that we're taking 2 different, it refers to the technique. It just refers to the electrical technique of taking the electrical activity of two different points over the surface of the head and subtracting them. And I'm going to contrast that to what we refer to as a referential mode of reading EEG, where each of these points in the brain is compared to a central area or a central mathematical construct. We can either take these 2 points and subtract them one from the other, or we can take each one of them over the entire course of the head and compare them to a single spot. We could compare them to the vertex. We could compare them to the average of all of the electrodes. If we add them up and divide by the number, we'll have an average. And so these different descriptions of what we call montages or displays, the ways in which we display the EEG on the screen, refer to whether we're comparing two different adjacent spots or points over the surface of the head. That's referred to as a bipolar montage, versus taking every spot and comparing it to a central location or to an average location. Besides seizures, it's helpful in assessing patients in the hospital that are in coma or that are confused, and getting a better understanding of how significant their brain's electrical activity is impaired in those instances. So yes, we use it for other things. On the outpatient side, it's largely for a detection of epileptiform discharges, seizures, focal slowing. If we have, it used to be before CTs and MRIs, we would use EEG to look for things like brain tumors, to look for things like trauma and scarring in the brain, because we didn't have the sophisticated imaging devices that we had. For some of those things, yes. Yeah. So this panel just basically illustrates the way in which these two different techniques, the bipolar and the referential, will display an abnormality. So on the left-hand side, you see the way in which a right temporal discharge would appear in a bipolar montage. Because these electrodes are placed very close together, we have very precise localization where these two spikes actually point towards each other. This is called a negative phase reversal. And because of the way in which these pairs of electrodes are organized very closely to one another on the head, when we have discharge that's occurring from an area within one of these chains, we're going to see this reflected by one of these negative phase reversals. So these are very easy to pick up as we're scrolling through several minutes or hours or days of EEG. And we have actually computer algorithms, sort of AI techniques that also help us to pull these out and save us a little bit of time. As you can see, it's a little bit harder to see in what we call a referential montage. You can still see it, but it's not really present. If it's coming from a narrow area, it's not going to be present in more than one or two of those channels, and it's a little bit harder to pick out. So the question came up, do we use it for other things? Yes, we use it for other things. This EEG, for example, shows mild slowing of the background activity. As I mentioned, the posterior dominant rhythm, which we can see in this fourth line, these top two chains, typically is about 8 to 12 hertz in a normal awake adult. Here we can count them up. Count 1, 2, 3, 4, 5, 6, 6.5, maybe 7 at times, but a little bit slower. Certainly 5 or 6. So this is a slow background activity. This could be a normal patient Speaking of which, so this would be an EEG that has, it's kind of riddled with epileptic discharges. Now this is the seizure, but these are very frequent, frequent epileptic form discharges. So we can see them every maybe one per second, 2 per second, 1 per second. There's 1 second that doesn't have any. These are very frequent epileptic form discharges. This is a pattern that we see in a common childhood epilepsy. It's a benign epilepsy that tends to be self-limited, and seizures remit on their own by the age of 9 or 10. Called childhood benign Rolandic epilepsy or childhood epilepsy with central temporal spikes. And we can see that each of these spikes has two peaks or two maxima. One is here over the mid-temporal, and one is here over the central. It's a very, very large field. This is a very typical drowsy EEG of a child with benign Rolandic epilepsy or central temporal epilepsy. And this is not a seizure. There's no, I'm going to show you illustrations of the seizure EEG, where you see evolution of patterns, continuous patterns. This is just, this is basically just contains very frequent individual discharges showing an area of cortical irritability that may give rise to seizures. Here's another patient that has both right and left-sided discharges. We can see in the upper chain, those upper 4 lines going across, left-sided discharges. It's at the 4th, the 6th, and the 9th second of this page. Every solid line represents 1 second. And then on the second channel of 4, we can see a couple discharges coming from the right. So this is a patient that has irritated areas coming in both hemispheres, one on the left, one on the right. These both happen to be temporal lobe. Here's another example of very frequent epileptiform discharges, similar to the one that I showed before. And then finally, I'm going to show you a picture. This is what a seizure looks like. So the technical definition, if we were just looking at the EEG, we didn't have a patient in front of us. This was just an EEG that was hooked up and then taken down, and somebody sent me the data to look at, which does happen. And I'm reading this, and I see initially some spikes in that first second and a half of the page. We see some spikes, and they seem to be a little bit more prominent over the left side than the right. Here's left, right. Here's over the central area of the brain, and then left, right over the top of the head. So they seem to be a little bit more prominent over the left, and then we see boom, 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 and it tends to, and it's continuous. We don't see any emergence of normal brainwave activity, and it tends to evolve over time. So this is the beginning of a tonic-clonic seizure that starts focal, it starts in one area, but spreads very rapidly to involve both hemispheres of the brain. Pardon? That would be this is one EEG appearance of a tonic-clonic seizure. Yes. And just for comparison, many of you will have heard of absence seizures. So absence seizures are a very different type of seizure. Here, the electrical activity, although it's manifesting in a similar spike and wave phenomenon, we don't see much evolution. It's not building up, it's not dying out. It starts, it's continuous basically for a period of 8 or 9 or 10 seconds. And then it stops abruptly, and every discharge consists of a spike wave, and those spike waves are predominant over the frontal parts of the head. So this would be a typical EEG depiction of an absence seizure. Again, we don't have a patient in front of us, but if this actually happens, probably once a month. I'll be sent an EEG or a video EEG of a child, sometimes with developmental disability, sometimes with autism or on the spectrum, and I'll see dozens of these throughout the day. And then sometimes we'll go back, we'll look at the video, and we'll say, oh yeah, they're slowing down here. They're on their phone, and they're just not playing that game, hitting those buttons or surfing the phone at the same speed. They're sort of frozen for about 10 seconds, and then they start up again. And that would be a typical absence seizure. And then finally, I'm going to show you an image from that's not a scalp EEG. This is an EEG that's derived from those electrodes that we can implant inside the brain. You can see there's a lot more lines. It's much more complex to interpret. And in fact, this is actually, this particular frame is a relatively small number of electrodes. Here we have about 8 electrodes inside a temporal lobe. We have in the past can have put as many as 14, 17. Some centers, depending on whether we're looking at one hemisphere or both hemispheres, might implant 20 or more of these depth electrodes. You have to turn the screen 90 degrees so that you can actually see all the squiggles going across the page. It can become very complex to interpret them. But what I wanted to point out is that sometimes we also have very clear depiction of focal seizures on these electrodes as they're implanted in the brain. As you can see here in this particular channel here, this is coming from the hippocampus, the body hippocampus. On the right, you can see the squiggles of about 10, 11 hertz that start at the second hertz of the second recording, gradually increase, and then slow into this 2 to 3 hertz activity towards the end of the piece. This will be the onset of a focal seizure from the head of the body. This is one example of seizures as we record them from electrodes that are implanted in areas of the brain that commonly give rise to seizures. So I don't have any more slides. I'm going to open it up to questions. Oftentimes people have certain things they want clarified. So did you have a question?
Yeah, so are they using more or less electrodes? Is it still the 1020 or are there other systems?
It's a great question. So there are not other systems, but there are modifications of the 1020 system. So you can pick distances in between the electrodes to place additional electrodes for more sensitivity in a particular area. So if
Let's say, for example, let's say they see activity in this one area, but they're not able to exactly pinpoint it between one electrode and the other, so they can run it again and put an additional electrode.
we don't have to write, that usually happens when patients are in the hospital for epilepsy monitoring. So yeah, we may see spikes in a broad region, let's say the right frontal lobe, but the electrodes are quite far apart, and we want to drill down on exactly where it's maximal, where is it most likely coming from. We might place additional electrodes in between the standard ones on the 1020. The modification of that is referred to as the 1010 system. So instead of using 20% of that circumference, we place electrodes 10% of the distance apart, more densely. Are there other questions? I thought I saw a hand up here. Yeah? So you ask a lot of, so it's a very good question. There's actually a few questions in there, and I want to tease them apart a little bit. If you have somebody that's come into the emergency room because they've just had a seizure in the field at home or whatnot, and they're brought in, the EEG is going to be more sensitive in the first few hours after that seizure than it will be the next day or the next week. So we always try, if a patient is in our grasp, right? They're in the emergency room, they're in the hospital, they're in the clinic, and they've had a recent seizure. We always try to get an EEG done as quickly as we can because we know that that's going to have a higher yield. It's going to show us more information. The other issues about where the seizures are coming from doesn't really matter whether seizure happened 10 minutes ago, seizure happened an hour ago, yesterday, last week. Those areas, some of those deeper areas are still going to be hard to pick up on the scalp EEG. Okay? Yeah. Yes, all the time. You have to be referred to a neurologist or an epileptologist who knows the right questions to ask and the right tests to order, because oftentimes what... Yeah. 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 So if there's still a lot going on, you need to go to the next step. You need to ask more questions, be your own best advocate. So, other questions? Yes, please. Yeah. That's a focal aware seizure. Yeah, we used to call that. You could call that an aura. We could call that we used to call it a simple partial seizure. So because there was no impairment of consciousness. Correct. Yeah. Yes. Yes, and I have that conversation with patients in the clinic all the time because they come in, and they check off the no, right? Have you had seizures since your last appointment? No, and then we get into the nitty gritty, right? And it turns out that, well, they haven't had any disabling seizures. They haven't had any convulsions. They haven't lost awareness or been confused. But once or twice a week, they have their aura, right? They have the feeling that something's going to happen, but it never does. They have the bitter taste in their mouth. They have the rising sensation in their stomach. They have the overwhelming deja vu. And I'm always educating patients in the clinic. Those are seizures. They are a target of therapy just as much as the bigger seizures are. 100%. Now, if you're on, 6 drugs and you've been struggling with control of convulsions, for years, then, obviously then it becomes a little bit of a balancing act between side effects and seizure control. But yes, if in a more routine scenario, when the disabling seizures are well controlled, we still want to address the minor seizures, the mini seizures, the focal aware. Mm-hmm. Yes, please. So it could be any of those things that I mentioned. It's essentially an aura. It's what people talk about as their aura. Very commonly, it's a feeling that something is going to happen, but it's really hard to explain. Some patients do describe dizziness, but it's not oftentimes vertigo. It's not spinning. It's just they can't get their bearings. Deja vu, strange smell, strange taste. The aura or the symptoms of the seizure coming really has to do with where the seizure is starting from in the brain. If it's coming from an area around the temporal lobes, it can be one thing. If it's coming from an area in the frontal lobe, it can be something else. I have many patients who have frontal lobe seizures, for example, and they have difficulty speaking. They can't get their words out, or it comes out as gobbledygook. And that's their aura. They know that if they don't take a rescue medication, and when they start having difficulty expressing themselves, they're going to end up with a bigger seizure. So, triggered by surgery? That sounds very kind of complicated. We kind of could be a lot of different things. I'm not certain that it's seizures. I don't know. Yeah, need to know more information. Yeah. Yeah. Uh-huh. So there are patients that have auditory. We refer to them as auditory hallucinations. They are typically voices, music, but it can be anything. But yes, I have had patients that. Yeah. Yeah. So I had a patient many years ago who described a sound attack. That was his term for what he experienced just before his convulsion. Yes. Yeah. One more question. Unfortunately, I have a noon meeting, so I am going to have to tie it up. Yeah, but I'll be around at the Hoag booth, actually right outside here for another hour or two afterwards. Yes. EEG is not diagnostic of autism, no. We do perform EEGs very often in kids with autism, especially ones that have had a developmental regression. So they've acquired motor control, walking, using their hands, speech, communication, and then they lose it at a later point in time. And so what we want to make sure is that they don't have an EEG that looks like this, because sometimes the loss of certain skills, typically verbal communication skills, but sometimes motor skills, can be the result of a lot of abnormal electrical activity. Not so much seizures, like discrete seizures, like that kid just had a seizure, but when they go to sleep, their sleep looks like this all night long. And that can be treated and improved with aggressive therapy. So that's why we do that. So, thank you for your attention, everybody.